Thanks for joining us on This Week in Health IT Influence. My name is Bill Russell, former healthcare CIO for a 16 hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Today, Dr. Dirk Stanley joins us. He's the CMIO for UConn Health, and he is a phenomenal writer, but he's really excellent on Twitter as well. He has a great blog around clinical informatics. And today we talk about his top 15 signs you may work in clinical informatics. It was a post he did out on LinkedIn and on Twitter, and we utilize it as a framework for our conversation today. Special thanks to our Influence show sponsors, Sirius Healthcare and Health Lyrics, for choosing to invest in our mission to develop the next generation of health IT leaders. If you want to be a part of our mission, you can become a show sponsor. The first step is to send an email to partner@thisweekinhealthit.com. I want to take a quick minute to remind everyone of our social media presence. We have a lot of stuff going on social media. You can follow me personally, Bill J. Russell, on LinkedIn. I engage almost every day in a conversation with the community around some health IT topic. You can also follow the show at This Week in Health IT on LinkedIn. You can follow us on Twitter, Bill Russell HIT. You can follow the show This Week in Health or in HIT on Twitter as well. We've got a lot of different things going on, and each one of those channels has different content that's coming out through it. We don't do the same thing across all of our channels. We don't blanket posts. We don't just, schedule a whole bunch of stuff and it goes out there. We're actually pretty active and trying to really take a conversation, in a direction that's appropriate for those specific channels. So we spend a lot of time on this. We really want to engage with you guys through this. We are trying to build a more broad community. So invite your friends in to follow us as well. We want to make this a dynamic conversation between us so that we can move and advance healthcare forward. All right, today we have Dr. Dirk Stanley, the CMIO for UConn Health, in with us to talk about clinical informatics. Good morning, Dirk. Welcome to the show.
Good morning. Thank you for having me.
I don't know why I say good morning. I'll assume that people only listen to podcasts in the morning. In the afternoon, they don't listen to it. I don't know why I do that. This is our first time meeting. I'm looking forward to this conversation.
And me too. I'm honored to be a guest on your podcast.
Yeah, it's going to be fun. We were talking earlier how we feel like we know each other because I've read so much of your stuff. I read your stuff on Health System CIO, and I see your stuff on Twitter and whatnot. You post some interesting things on Twitter. I remember the one post you had, you were describing a terminology and you had like a graphic with oranges and those kind of things. Actually, I should have had it pulled up, talk about it. Do you remember that post?
Yeah, I was just trying to explain how my terminology matters so much for usability and trying to explain, because sometimes understanding the difference between apples and oranges and fruit, they're all related, but they're sort of different. And when you look at those terminology things, it's helpful to make software more usable and less clicks. So these are and sometimes people don't appreciate how the terminology results in extra workflow challenges, but once you harmonize that terminology and really get it appropriate for the clinical purposes, it often helps reduce clicks. So that's what that post is about.
All right. Well, we're gonna have a little fun. We're gonna demystify clinical informatics a little bit. We're going to do that by using your top 15 signs that you may work in clinical informatics as a framework for our discussion. So you posted this on Twitter, and did you intend it to be funny? I mean, because I've talked to people, it's kind of funny.
Yeah, actually, I did. I was thinking I had one of those moments where I'm like, boy, I wish people understood what my life is like. And then I drew some inspiration from David Letterman's top 10 list. And initially it started as a top 10, but then I kept going. I'm like, oh, I have a top 15 here. And I knew I struck a nerve because so many people shared it and commented on it. So I guess I hit a nerve. It was great.
Well, here's what we're gonna share the top 15, and some of them I'm just gonna throw questions in afterwards because I think it's a great framework to talk about what you do and how you do it and how you go about doing it. So the 15th, I guess, the last one is your IT friends think you are too clinical and your clinical friends think you are too IT. I've heard that a fair amount. Let me ask you this. What makes a good clinical informaticist? What type of person should go into the field?
Other than, there's lots of punchlines I have here, like seeking abuse or punishment, or but like it's being a translator, right? It's like being an interpreter. Somebody who, my dad was a military interpreter for a while when he was in his military career, and he was an interpreter, and he always taught me something that kind of stuck with me. Like, good interpreters spend half their time in one culture and half of their time in another culture, and they have to learn both cultures to be an effective interpreter. And I think clinical informatics, and it's the same sort of principle. Like, you need to be able to spend some of your time in IT and some of your time in clinical. And once you understand their customs and their traditions and their words and their culture, then you become an effective interpreter between the two. And I guess that would be my answer.
Well, I'll tell you, I've sat in those meetings where we're trying to take a single word. I've talked about this on the show a couple of times, or a single event in the hospital. We're going, okay, let's define this. And it's not, you look at it and the terminology, you're like, this is easy. I mean, this should be a 5-minute meeting. 3 hours later, you're sitting there going, all right, we have 6 definitions for this what appears to be very simple thing. And the problem is it shows up on 150 reports that go out. So don't we have to get to a single day? I mean, is that one of the bigger challenges that you have, is defining the terminology and getting the terminology right?
Yeah, I think it's funny because when people hear what I do, they're like, well, you must be kind of a doctor, or maybe you're like an IT person, maybe you do technology. But really, a lot of it is exactly what you said. It's about understanding both cultures, and terminology is so important. It's so critical for effective communication between the two. And I often sit there in meeting, like it sounds like you have too, where you're watching both sides talking at each other, but they're not quite communicating. And once you like kind of really like narrow in on like what is it going to take for the communication to be established, suddenly it changes the whole dynamic, and you can almost see the lights go on as both sides are like, I see what you're looking for. And it's awesome watching solutions then fall into place. It's really great.
Yeah. So so one of your next ones is, you have successfully used the words ontology, hierarchy, indexing, and usability in a Scrabble game. Those are fun words. I would ask you to define all of them, but these are also extremely important. Ontology, again, we get back into the definition and categorizing things. Indexing, usability is huge, which gets to your next one, which is, in your spare time, you write poetry about interoperability and meaningful use. That really has driven, so meaningful use really has driven a lot of the work of clinical informaticists for the better part of a decade. Is that still the case? Or are we starting to move into maybe a new era beyond meaningful use?
I think, and about ontology and hierarchies, like clinical informatics has its own language, right? Like its own sort of vernacular and traditions and customs. I think just like watching the interpreters at the United Nations, right? They have their own internal ways of handling things and certain protocols. I often think, for example, by the way, about like, you ever wonder who the interpreters were who were trying to interpret during the Cuban Missile Crisis, right? And you have like 2 world leaders, one speaks Russian and one speaks English, and you're like, ooh, I better make sure that we're interpreting this right. And so those same sort of standards, that's what
So interpreters can start wars or escalate wars, is essentially what you're saying.
Right. You're probably like, yeah, like if you're not careful about how you interpret, like, yeah, you could potentially, the whole negotiation can fall apart through a bad interpretation. So that's when I'm referring to ontologies and hierarchies, it's about like, what is the language of clinical informatics? And getting back to the writing poetry about meaningful use, I mean, I think most people would agree that meaningful use really set the ball in motion, and the ship started to sail with meaningful use. But now we're like entering all new waters, and there is a new, like, I think we're breaking new ground in terms of interoperability and usability. And I look forward to seeing what the next 10 years brings us. But yeah, these are the type of things when I was like, if you had to write like haiku about meaningful use. What would it look like, right?
Yeah.
So,
Well, and it's your next one is you keep looking for ways to optimize the workflow for walking your dog. There is sort of a mindset once you get locked into efficient workflow and those kind of things. That's half joking, but all of us have been there. Like you do it at work all the time, and then you come home and you're like, this house could be a lot more efficient. We could do this. Do you drive your family crazy with some of that stuff?
Yeah, I keep asking my dog, like, could you walk yourself? Do you think, would you be able to, like, he hasn't answered me yet, but yeah, like it starts to permeate. You start looking for like, if, like, I remember the moment I started to wonder, like, if we put in our kitchen, if we put the knives on the right side and the spoons on the left side, would there be like a time saving somehow? Like, or if you've ever organized your closet, like, okay, is there any benefit? Why do I have my socks in the top drawer? Maybe, like, is there a benefit? Like, maybe I should move the socks to the bottom drawer. It does start to impact your life.
Yeah. So have we turned the corner on EHR usability, do you think? Are we getting to the point where we are fine tuning things, or we still have big movement to go here from a usability of the technology, from a improvement of the workflow, from integrating all the different disparate systems and data stores that we have out there?
It's hard. Like, usability and interoperability are very difficult, complicated things, and there's so much that goes into making systems usable. And I mean, I think it's getting better, or at least people are recognizing the issue more, but there's still a long way to go. I remember, I think it was at HIMSS a couple of years ago, I saw somebody once lecture. I apologize, I don't remember who brought this up, but they said that, like, good clinical decision support feels right. Like, it feels like you're walking down the street, and just at the moment when you're thirsty, somebody hands you a glass of water, and when you're hungry, somebody hands you food. Like, it should feel natural, and it should feel right. And we're not quite there yet. Like, I think there's a long way to go in terms of, like, how do we know when doctors and nurses feel thirsty? Like, we want the EMR to give them what they need at that moment, not before and not after. So to really, like, help improve usability, we need to understand workflows better, and we need to understand what information they need at the moment when they make the decisions that they do for patient care. Like, and another example that I often use when I'm talking about it is, if you were in the physical world and somebody built a set of stairs and you walked up the stairs and, like, there was nothing at the end of the stairs, like no door, no window, no light switch or anything, you'd probably be like, why did somebody build the stairs here? And then eventually you might kind of walk down the stairs and go about your business. That's the type of thing. There's still pieces of that, like the virtual equivalent of that still happens sometimes. And I think in terms of usability, clinical informatics really has an important role in making sure that when the stairs are built, that whatever's supposed to be at those stairs is there too. And that's not a future upgrade. You want to release them at the same time.
Yeah. But we actually have a lot of information now. Just digging around the EHR, you can get full-blown reports on, using your vernacular, who's thirsty, right? Which clinicians are thirsty. They're using the EHR maybe at a suboptimum level, and you can identify. Is that where you identify? Is that how you identify projects, or do the projects really bubble up more from the operation?
Usually they don't. I don't have to work too hard to identify the projects. Usually it's somebody knocking at my door like, Dirk, you got to look at this. This is like, I walked up the stairs and there was no window, there's no door, there's no nothing. Like, what's going on here? So the projects usually identify themselves, but there's opportunities. Another way that I often see opportunities to insert better workflow design is really in the project intake. Like, when people are requesting any sort of technology implementation, you want to insert design thinking at the beginning, right? Like, in the way you analyze it, who's going to be using the technology, how are they going to be using it, for what's the clinical purpose, what is it to treat pneumonia or to treat cancer or to treat COVID? What are they trying to accomplish? Who are the people? It's not just the doctors, it's the nurses and the pharmacists, and even medical records plays a role in all this. And like knowing who are the people who shape that particular workflow and then bringing them together and talking about it and getting their agreement. And then you can kind of like figure out where the big decision points are, like where sometimes nurses have certain decisions that lead them down to branches. And you look for those opportunities where, like, what can we give the nurse to help them with that decision? And same thing with doctors or pharmacists. So you learn a lot about like the DNA of healthcare as you're doing this.
Yeah, you really get into you get a pretty deep level of what's going on. Getting back to the list, you get panic attacks every time you hear the phrase new federal regulations. Well, we get to hear those phrases pretty often these days. So let's talk a little bit about 21st century cures. Are we ready for the information blocking rules and the API rules at this point? Do you feel like we're ready? And what kind of impact do you think that's going to have on interoperability?
It's going to be interesting. I think there's the like kind of frontline experience of this, which is not always easy to navigate. Like there are people who don't want to learn about a life-changing diagnosis in the electronic medical record and not have the provider around. I think there's almost a generational sort of divide. I don't know what year it is. Every birthday that I have, I keep thinking like maybe I'm still on this side of the fence, but you know, I don't know exactly where the line is. But there are people who legitimately don't want to get like unhappy news in the portal if it's there to help kind of frame it. On the other hand, there's many people who are like, I want my data, like it's my data, I own it, like it's not unlike a bank, right? If I deposit the money in the bank, I have a right to withdraw it anytime I want, and nobody should ask me any questions. I can use my money for whatever I want. And navigating that generational kind of divide, if you will, or at least that transition, is what I think the biggest challenge is in developing these regulations. That being said, overall, clearly the benefits outweigh, in my opinion, the benefits outweigh the costs as a society. But on the individual level, you want to make sure that every patient gets the respect and care that they need. And so how do you do that? How do you balance the greater good with like the individual needs of each patient? And that I think that's the cultural challenge of it. But personally, I've been a proponent for patients having access to their records. I think there's so much opportunity for interoperability and even just like patient empowerment, allowing patients to, once they have access, like a fully transparent, fully portable chart that they can take anywhere, then if they're not getting the service that they need at one hospital, they can very quickly go to another hospital for service. And I think it'll help drive competition, improve service, improve quality. So I certainly see why we're doing this year, but sort of figuring out the cultural nuances of this and making sure that you're meeting every patient's needs. It's kind of hard sometimes when you're looking at the big picture, and I've had patients like complaining to me that they learned about something that they didn't want to inside the portal, and you want to be sensitive to their requests. Like everyone is important, and so navigating that is a lot of work and takes a lot of planning.
And this is the interesting space that you sit in, right? So you're talking to the clinicians and you're understanding the system and the clinician needs. You're hearing from the patient, understanding the patient needs, and you're looking at the technology. I mean, because when you talk about that, I'm a technologist by background and trade. I think, my gosh, that's just a simple setting that you can put into the portal. They click it, you categorize all diagnoses, and instead of just sending them to the portal, again, you're doing it at the patient level. So I get to set the setting that says, I want to receive it, or I want to talk to a doctor. I don't want to receive in my portal. I could just click a button and then I'm not going to get it. So next time somebody says, hey, I don't want to receive it, it's like, great, go into your settings, hit this. You won't, you'll receive an alert that it's available, but you won't receive it unless you want to receive it.
I think that's the ideal situation. Like, patients should be able to make that decision, right? But I think different vendors have different opinions about this, or maybe some vendors haven't quite developed that functionality yet. But we need to. I think eventually, though, I can see most vendors eventually supporting exactly what you're talking about.
Yeah, 21st Century Cures is interesting because it's literally an end run around the people that have owned the data for years, and it's making it available to the larger community. So that'll be another thing that you have to wrestle with. All right, back to the list. When bringing your car in for routine maintenance, you ask the mechanic about the ROI and TCO of your future state. Yeah, actually, I mean, you bring it up. So how do you measure to ensure the projects are meeting the financial return goals for your organization? Is that something that you guys have a pretty good handle on at this point?
I think, it's a work in progress with pretty much everyone I speak to, but it's an interesting challenge because there's sort of the quantifiable benefits of the technology. You can talk about throughput, and if we can see another 10 patients a day, we can quantify that. Or there's sort of the tangible benefit, but then there's the intangible benefits, like what does it mean to prevent medication errors? What does it mean to make patients happier with the way they get their results? What does it mean to make your staff happier, that they don't have to click 15 times to do something, they can only click once or twice? And it's sort of, how do you measure those intangible things? And especially when it comes to healthcare, right? Healthcare is there's so many gray situations, and figuring out those intangible benefits is always interesting. I've had people say there's no way to measure it. There's no way to measure the happiness of your patients or the happiness of your staff. I think there are actually ways, at least you can kind of estimate them, and they need to be part of the equation. To just measure it in terms of financial benefit, there are opportunities to miss improving patient safety and improving staff or patient satisfaction.
Yeah, I found the projects where you can just do the very clear ROI, they get approved very quickly, they move very quickly. The other ones, in some cases, very important, recognized by a lot of people to be necessary within the health system. You'll struggle to get them approved if they don't have that strong financial return. And then you have to go into the making the case around all the other aspects that you just talked about, some of which are quantifiable, some of which not as quantifiable. And so that's a hard part of the job, I think.
It is, and it's hard. At the end of the day, these are difficult discussions and decisions, but it's important. I do think it's important to at least try to understand those intangible benefits.
All right, I'm gonna hammer out a couple of these. Next one, your friends stage an intervention after you start inviting them to flowcharting parties. Yes, this is the new Pictionary, is a flowcharting party. That would be fun. Although I'll tell you, the most impressive flowchart I've ever seen was we were migrating from one EHR to another, and we brought people in from all over the health system, and they put up this flowchart that literally went around the entire room. It was unbelievable. But it was really, it was impressive to see, first of all, the complexity of all the things that we were doing, the fact that there are experts who really understood it and could put it on a piece of paper, I think, which somewhat defines that you can understand it. And then it really helped us with the build after we got all that stuff down. All right, let me just go to the next one. At bedtime, your kids protest, we're tired of discussing project intake and change management. Can we just go to sleep? Hey, project intake, that's pretty important. And you talked about it a little bit earlier. How do you prioritize the stuff? Do you have, is there a governance process, or how are you prioritizing the work? As you said, the work finds you. It's people knocking on your door. How do you get it into the pipeline?
So I have my sort of dream fantasy scenario where people are like kickboxing and whoever's left standing like gets their project done first, right? But, but apparently like there are better ways to do it than that. Again, prioritization is an institutional function. Like knowing what to work on is something that every institution really needs to spend time developing a process and governance. And you want to make sure that when projects go into, let's call it the project bucket, that the easy, the low cost, high benefit projects identify themselves, and also the things that are clear safety issues or risks to the organization also need to identify themselves. And the low benefit, high cost projects kind of bolt down in the list. So how you actually measure that? What are the questions you would ask to know, is this a low cost, high benefit, or is this a high cost, low benefit? Though getting those questions right is really requires a lot of sort of strategic planning and thinking, and you want to develop algorithms like measurable like ways of constantly looking at those projects. And there are some very impressive tools that I've seen and that I've personally helped implement, where you're looking at the risk to the organization and the risk to patients, that brings things more to light, and those topics get discussed. Personally, in my role, I discuss every project, like whenever people have ideas, they come to me, and I listen to it, and I try to give my own personal analysis of it. But it's very helpful to have a formal methodology for it, because otherwise it becomes one person's opinion versus the other, and that can lead to arguments.
All right, so people knock on your door. I assume things fall into, some things are just tasks. They just need to get done. Some things are a little bit more than a task. It's an enhancement, something that needs to be enhanced. And then some things are full-blown projects. Is that a determination that you're sort of making, that where you're going, look, I'm just going to funnel this over to my team and they'll take care of this, or this has to go through a larger governance? Does that squarely sit on your shoulders, or?
No. So actually, fortunately, I work with a really great team. We have our vice presidents, our project manager. We have a new head of our project office, and we are like it's, everyone knows what we need to do, and we continue to enhance this process together. But health IT is a team sport. There's no doubt about it. Like, you have to work with all these people because everyone has important contributions to that discussion. It's really an enterprise discussion, right?
Yeah. So if it becomes a project, one of the challenges that I had when I was CIO was who builds the financial model, right? So in the planning phase, everybody had a chance to bring forward their projects, and you'd end up with, this is not an exaggeration, you'd end up with hundreds of projects. And then invariably, you want to sort of that risk reward and investment. You sort of want to look at that whole thing to determine, which projects you should be doing. But someone has to build out the financial model, and in some cases we put that on the individuals to build the financial model. And we just found the financial models to be just flat out wrong, had to be redone because people have different skills and those kind of things. How do you get the financial models? I'm asking, this is like free consulting. I'm asking you to help me. How do you get those financial models to be as accurate as possible so you can make the best decisions you can make?
Well, so everyone struggles with the same issue. I'll just say that everyone has the same sort of challenges. One of the things that we're currently experimenting with is basically a second set of eyes to like kind of a system of checks and balances. Like, there's the first sort of estimate, and then another person basically goes through the same process, and if they both validate each other, then you have evidence in the financial model. But sometimes there are discrepancies. But we're still trying to figure out, though, because if you're going to do that sort of a process, you basically need two people to do one function. And so we're still balance that out. Like, can we make, maybe the first financial model will be on the local user level or in the department that's making the request. And then the second one would be from finance, or like, so we're still trying to kind of work that out. But I think everyone, kind of struggles with the same sort of things.
Yeah, no, I could see that. All right, so your list, I'm probably going to skip a couple here, go to the last couple. So you've wondered how to increase global awareness about the complexity of order set design. Gosh, I was just going to rifle through, but I'm going to stop there. Why is order set design so hard?
So, so I'm so glad you asked me that question. So order sets are like, I don't know, are you a Doctor Who fan? Do you know, are you familiar with
Oh,
Doctor
yeah,
Who?
absolutely.
The TARDIS, like on the outside, it's a phone booth, and then you go inside and it's like a whole world inside.
Yeah.
That's like what order sets feel like. When you're on the outside, it looks like you're like, it's, I don't know, there's like 20 orders here, or maybe 40 or whatever it is. Like, but on the inside, to get to those, like, it's not just about what the orders are, it's what the defaults of the orders are, like what fields the orders need to ask, who reacts to the orders. Like, it's not just about the person entering the orders and submitting the orders, it's about the person who receives the orders. And then, does the order actually contain the information that you need to execute the task that's at the end of the order? And so, like, when you have medication orders especially, there's a lot of information you need in terms of the route, the priority, the frequency. Is it a one-time order or a repeating order? Is it an inpatient order or an outpatient order? With lab orders, are you expecting, who's going to collect the lab? Are you expecting the phlebotomist to collect it, the nurse to collect it? Are you expecting the patient to walk to the draw station and get it collected? Like, there's so many details that need to be worked out. And so, it's a frequent thing. I think most CMIOs will tell you, people come and they go, oh, I got a problem. I want to make a little order set for whatever. And you're like, okay, let's start examining it. And then you start suddenly you find out there's a whole blossom of workflows that you have to kind of tackle to make that order set work.
Well, and clinicians are very passionate about the order sets. I mean, they will look at it and go, no, this is the way it should be, and this is how it should be. And then you'll have a doctor sitting right across from them going, where did you learn medicine? That's nuts, kind of thing. And I've sat through those conversations, and I'm glad I had a great CMIO who would sit in those conversations, and I attended a handful of them, and then I was just like, you're as much an ambassador for, bringing two sides together as, there's an awful lot of people work and coalition building and that kind of stuff to get this stuff done, is what I've seen.
The trick to that situation that I always I really embrace this, is you have to start with the clinical care first, right? Like, just start what is good patient care? Like, you describe, if you have two doctors who disagree, just start with what does good patient care look like to you? Like, what do you imagine? Give me your most mouth-watering scenario, almost like gourmet food. Like, what would the best cheeseburger in the world look like? Would it be on a ciabatta? Or will it be what kind of meat, what kind of cheese, would you want red onion? Would you want white onion? Describe to me what you want. And then once, usually both sides want the same thing. But then once they describe it, then what I usually do is I take my, laptop, whether before it was in a conference room, but now it's by WebEx, and I literally start okay, you said you wanted a burger, here's the meat, and then here's the cheese, and I start laying it out in front of them, and they go, yeah, that's what I want. And that's a way of getting them to align. It's really about best clinical practice, right? And and in those areas where they still don't agree, then we go to the literature, like Up to Date or another product.
Yep.
I'm trying to figure out well, what does the literature support? Sometimes I'm going through medical journals or in our medical library, researching the literature. So.
Yep. All right. So your number 3 is your retirement planner asked you, are you sure you want to do this? So I'll ask you, are you sure you want to do this? How difficult is it? Do you still practice?
So I'm not practicing right now because I'm I'm effectively managing the clinical informatics for a large academic institution. People always ask me, do you miss the bedside? I do miss the bedside. And I'm currently exploring ways of returning to the bedside to some degree. I think we're looking for opportunities to, I guess, get additional informatics resources that probably make that more manageable for me.
How did you, all right, so at some point somebody said, hey, do you want to do this? And you had to sort of weigh the pros and cons. Walk us through that decision of going from a full-time practicing clinician into informatics and then eventually leading an informatics team.
So I think everyone, I would love to hear you do it. Like everyone kind of falls into this somehow. For me, I actually started as an IT person before I went to medical school. And so I started off in a small software company, and then I went to college. Actually, I started off in IT before college. Then I went to, I guess that's sort of a weird story. Let me think about that. So I started off like working after school in high school, doing server maintenance for a small software company. Then I went to college, came back after college. I did consulting. I worked for some large, I'll just say, technology firms. I guess I don't need to drop their names, but I worked for some companies. And then I would say I got a little maybe burnt out of technology for a little while. And then one of my friends, his mom was a nurse, and she said, Dirk, like, why don't you come and volunteer here at the hospital? At least it'll get you out of the house. I was sort of in that post-college, like trying to find your way sort of. So I started volunteering at the hospital. And of course, they looked at my resume at that point, and they were like, oh, you got to work in the IT department. So I started working. This was at the Westchester Medical Center when I started working in their IT department. And that led to a data analyst position. I worked in their quality department. That led to a lot of projects where I was generating data, but I kept wondering, like, what is the central line? Like, they keep talking about a central line. So I'm actually that person who once sat in a meeting and said, can I just ask, like, why does the central line get infected and never the line on the left or the line on the right? And they were like, you're an IT person, you don't get this stuff. So, but I wanted to know, I wanted to know what were these things that we were studying. And that's what led me to apply to medical school. And the funny thing is, after I was in medical school, and now I'm wearing a white coat and a stethoscope, and I saw what was going on with the computers, and I said, I think there's a better way of doing that. And they were like, no, you're a doctor, you don't understand anything about IT. And I'm like, I don't understand. 2 years ago, I was on that side of the fence. Now I'm on this side of the fence. So after residency, I did my residency at Albany Medical Center. And I started applying for hospitalist jobs because that's what direction I was headed in at that time. But when I was applying for jobs I'll say my previous employer, they looked at my resume and said, like, wait a second, you have all this like IT experience and data. We would like to invite you to be our CMIO. And that's basically how I got my foot in the door. So,
yeah, they made you an interpreter is what they did.
I guess I've lived on both sides of the fence, so I became the de facto interpreter.
Actually, I'm going to throw out an odd question just because I want to know the answer. Where does nurse informatics sit at UConn? Is it its own deal, or does it fall under the CMIO?
So I would say informatics as a general topic is a discussion. It's an ongoing discussion. We don't really have I wouldn't say we have a formally recognized nursing informatics group. I currently live with a nurse informaticist who is outstanding, and together we solve a lot of problems. But I'm hoping the clinical informatics discussion continues to evolve, and that we develop more formality around the roles.
All right. Hey, so the last two here, you nod and smile graciously every time someone asks you, you work in IT, right? It must be fun to work with those computers all day. Now, you know what cracks me up about that? Everybody who's sitting in front of a Zoom meeting all day, who once said, it must be fun to work with those computers all day, are now stuck sitting in front of computers all day, and they realize It's not as much fun as they think it is. Your number one is you spend countless holiday gatherings trying to explain clinical informatics to your in-laws. I would imagine that's an interesting conversation with your in-laws. It's like, all right, so let me get this straight. Are you the CIO? No, I'm not the CIO. So are you practicing? No, I'm not practicing. What are you doing again?
And what do you do? You're something with computers and doctor, I don't know. You're like kind of, I'm like, yeah, something like that.
No, that's great. Actually, we're coming to the end here. I wanted to touch on a couple things. So we're actually recording this. It's the 4th or 5th. It's the 4th of December. Big event. So we have some vaccine coming to us. I just wanted to touch on a little bit from your perspective. You're like a process guy. You're the guy who looks at it and says there's got to be a workflow, a thing. What are some of the things you're thinking? We have some challenges in front of us, just logistically tracking it and all those other things. But I think some of the bigger challenges are we've got a 2-dose regimen coming in. That's going to be interesting to track. We've got to track it within our hospital in the EHR. We've got to track it in the community. There's a lot of challenges coming your way. Is there anything you're able to talk about at this point in terms of how you guys are thinking about it or how you're thinking about it?
No, I mean, I don't have a lot to share because it's an ongoing discussion. Fortunately, we have a really great pharmacy who's working on this. We have really great clinical leadership. We're having almost like daily meetings about this, also with our IT team. And there are a lot of like details to this workflow, and we're still kind of like developing them. And
this is a gnarly puzzle. I mean, it's like it starts with supply chain. You're not going to get like 1 million doses in the first week. You're going to get a certain amount. You got to figure that out. There's recommendations from the CDC of who gets it. There's storage challenges with this. You may not have enough refrigeration units and stuff. I mean, this is one of those really interesting Rubik's cubes to get all this stuff to line up.
COVID as a whole, like the whole pandemic for the last year has been a very challenging time for clinical care and for clinical IT, because there's so many details that need to be mapped out, and doing them this quickly has really been a challenge. Again, though, I work with a really great team. I'm very fortunate and very blessed to work with a great team who everyone's pulling up their sleeves and working together. And if there's any kind of like maybe long-term benefit to this, it's that this is broken down silos. This has like people are understanding each other's roles better. There's so much more collaboration, and even just the online experience has like shortened the development time, because in the past you would have a meeting, people would discuss things, but then there was always kind of a follow-up, like, oh, if you want, I'll send you a copy of the order set that we're working on, or I'll send you. There are always these like action items after the meeting. Now with all the online conferences, you don't even need to. You just pull up what you're looking at and you edit it in real time with the people that you need. And so that's been, I would say that's been sort of a time saver in some ways. So more to come, but yeah.
Dirk, I want to thank you for this time. I also want to thank you for your contribution back into the industry. I was reading your blog. I think it's a blog, technically, if that's what we're still calling it. But man, you really detailed some of the work that you're doing. And I would think if I'm a clinical informaticist, that would absolutely be a blog that I would be subscribed to. Just the detail and level of stuff that you're sharing, I think would be really helpful for anybody who's trying to attack some of these problems. So I appreciate that. Hey, how can people follow you, and how can people find you on the web?
Sure. So super easy. www.dirkstanley.com. That'll get you to my blog. I'm also on Twitter. I'm at Dirk Stanley. I've recently trying to develop a little bit slightly more professional version of my Twitter. So there's at Dirk Stanley MD, but either one will effectively get to me. I'm hoping eventually to put out more clinical informatics resources for people. I don't I'm not doing this for any sort of financial or there's no, I'm a very vendor agnostic sort of person. I think it's about clinical people learning how to engineer their workflows. And there's something that's very empowering when people learn how to design their own workflows. And that's the kind of stuff that I share on my blog.
Yeah, it's fantastic. Dirk, thanks again. I appreciate the time.
Thank you so much.
What a great discussion. If you know of someone that might benefit from our channel from these kinds of discussions, please forward them a note. They can subscribe on our website, thisweekhealth.com, or you can go to wherever you listen to podcasts, Apple, Google, Overcast. That's what I use, Spotify, Stitcher. We're out there. You can find us. Go ahead and subscribe today or send a note to someone and have them subscribe. We want to thank our channel sponsors who are investing in our mission to develop the next generation of health IT leaders. Those are VMware, Hillrom, and Starbridge Advisors. Thanks for listening. That's all for now.